Good morning. Good morning. Please take your seats. We're about to start this session. My name is James Hakim from the University of Zimbabwe, and my co-chair is Sasi Sopin. She has allowed me to use her first name only because the second name, as some of you might see, does take a little bit of an effort. She is from Mahindol University. We have 6 excellent presentations, and I'll introduce the first 3, and Sasi Sopin will introduce the next 3. We have 10 minutes presentations for each speaker and 5 minutes for Q&A. So we have microphones, all numbered. If you have any question, just go to one of the microphones, and after your question, the speaker who will be standing here will respond, but at the end of 5 minutes, they will then retire to their chairs. Okay. All right. Okay, thank you. Our first presenter is Nanina Andreg, who is a PhD student at the University of Bern. She's going to make a presentation on immunodeficiency at the start of combination antiretroviral therapy in low, middle, and high-income countries. Nanina, just click on your presentation.
So I'd like to thank the organizers for letting me present, and would like to welcome you all to my presentation about immunodeficiency at the start of antiretroviral therapy in low, middle, and high-income countries. Over the past few years, WHO has released several guidelines on when to start ART. The first ones were published in 2002, where they recommended starting therapy at the CD4 cell count of 200 cells or less. This CD4 cell count threshold was repeatedly increased in newer guidelines over the following year, until in 2015 the famous treat all recommendation was published, where WHO recommended starting treatment at any CD4 cell count. So let us now think of an ideal world where all patients are diagnosed directly after HIV infection, and all programs are able to implement guidelines immediately. Then we would see the following picture if we looked at the CD4 cell count of patients that start ART. Patients that started ART between the year 2002 and 2009 would have done so with a CD4 cell count of 200 cells. Between the years 2009 and 2013, they would have started with a CD4 cell count of 350 cells. Between 2013 and 2015, they would have started with a CD4 cell count of 500 cells. And now, since 2015, patients that start therapy would do so with a CD4 cell count somewhere above 500. But of course, we are not living in an ideal world, and patients are not diagnosed immediately after HIV infection, and programs are not able to implement guidelines immediately. So what we wanted to answer with our study is the question, how far off are we in the real world from this picture of an ideal world? Or more specifically, we wanted to describe temporal trends in the CD4 cell count at initiation of ART in adults in low, middle, and high-income countries. To do so, we used routine HIV data from 2 large collaborations, the IDEA collaboration and the COHERE collaboration. IDEA stands for International Epidemiology Databases to Evaluate AIDS and consists of 7 regions, 4 of them in sub-Saharan Africa, then the Asia-Pacific region, the Latin American region, and the North American regions. So IDEA has data on all continents except Europe. COHERE stands for the Collaboration of Observational HIV Epidemiological Research in Europe and provided us with the data for Europe. For our analysis, we only included adult patients that started therapy between 2002 and 2015. For those patients who didn't have a CD4 cell count at their therapy start reported, we imputed the missing CD4 cell count using predictive mean matching. We aggregated data by country, calendar year, and sex. So for each country and each year, we calculated the median CD4 cell count at therapy start of all patients that have started therapy in that country and that year, and we calculated the percentage of patients that have started with severe immunodeficiency, which was defined as having a CD4 of below 200 cells. So these two were our main outcomes of interest, and we wanted to see how they evolved over time. To do so, we estimated time trends of the two outcomes by income group and sex using weighted generalized additive mixed models. These maps shows all the countries that have contributed to our analysis. The different colors correspond to the different income groups. So red represents the low-income countries, green, the lower middle-income countries, blue, the upper middle-income countries, and purple, the high-income countries. Overall, 55 countries contributed to our analysis with almost 1 million patients, most of them from lower middle-income countries and low-income countries. 57% of patients were female. This number was a bit higher in low and middle-income countries, ranging from 60% of female patients to 64% of female patients, and clearly lower in high-income countries, where only about a quarter of patients that started therapy were female. The median age at therapy start was 35 years. Again, this number was a bit different in high-income countries, where patients tended to be older when they started therapy. The median year of ART initiation was 2010, and for 33% of patients, there was no CD4 cell count reported at therapy start and had to be imputed for our analysis. So let's now look at our first outcome of interest, the median CD4 cell count at therapy start. Here you can see the estimated median CD4 cell count at therapy start and how it evolved over time. What we can see is that the median CD4 clearly increased in all country income groups in males and in females. So the males are on the left-hand side and the females on the right-hand side. Relatively seen, the highest increases were in upper middle income and low income countries, so in the blue and red curve, followed by lower middle income countries and high income countries. If we compare the increases in females to the increases in males, we can see that in all country income groups, the increases in females were more pronounced compared to the increases in males, except in high-income countries where actually the opposite was the case. So where males had higher, more pronounced increases in median CD4 at therapy start. What we can also see is that even though we have a really nice increase over the years, if we look at our last study year, we can see that none of the country income groups reached levels of median CD4 cell count at therapy start which were above 350 cells. So let's now come to our second outcome of interest, the percentage of patients that have started with severe immunodeficiency. Here you can see how this percentage has evolved over time. What we can see is that the percentage starting with severe immunodeficiency clearly decreased over the years, again in all country income groups in males and in females. The largest decreases were seen in low-income and upper-middle-income countries, followed by high-income and lower-middle-income countries. Similar to before, females showed more pronounced decreases in all country income groups except in high-income countries, where again the opposite was the case. What we can also see is that even though we have a nice decrease over the years, if we look at the year 2015, we can see that in all country income groups there were still above 20% of patients that have started therapy with severe immunodeficiency. And what can also be seen, if we look at the high-income countries at the last few years, we can see that the proportion of patients starting with severe immunodeficiency seems to have plateaued and doesn't seem to decrease anymore. So in summary, we have seen an overall increase in the median CD4 cell count at therapy start, which was most pronounced in low-income and upper-middle-income countries and more pronounced in females compared to males in all income groups except high-income countries. But we have also seen that if we look at the year 2015, that all country income groups still had a median CD4 cell count at therapy start, which was below 350 cells. For the proportion starting with severe immunodeficiency, we have seen an overall decrease, again most pronounced in low-income and upper-middle-income countries and more pronounced in females compared to males in all country income groups except in high-income countries. If we look at the year 2015, we have also seen that there are still more than 25% of patients that have started therapy with severe immunodeficiency, and that this proportion that started with severe immunodeficiency seems to have plateaued in high-income countries. So let's now come back to our initial question of how far off are we in the real world from this picture of an ideal world? Well, if we look at our study, we have to say that even though we see a nice increase in the median CD4 cell count at therapy start, we are still quite a bit off, especially in the last few years. So that's why we think substantial additional efforts and resources are needed to increase testing coverage with the aim of achieving earlier diagnosis, linkage to care, and initiation of ART globally. I'd like to thank the IDEA collaboration, the COHERE collaboration, and you all for listening. Thank you.
Excellent. Thank you very much for keeping to time. And if you can wait there for a few minutes, we'll take some questions. Let's see. Right. Are there any subgroups in the different regions that particularly did well? I know you made a comparison between male and female, but any other subgroups?
Well,
even, age bands or any groups that probably did well?
Well, for this analysis, we didn't look at particular subgroups. We only looked at the differences between males and females. What we did was an analysis which didn't look at the income groups, but at different regions. And there we could see quite large variation. So, for example, North America did much better regarding the median CD4 cell count than the general average we have seen for the high-income countries. And South Europe, for example, did a bit worse than the average we have seen before.
Thank you. Number 5, Ken. Number 6.
Ken Friedberg from Mass General Hospital. Thank you. I'm wondering if you could split apart your last conclusion about the 3 components, that is, when people are tested, whether they're linked, and then when ART is started. So your focus was on the third part, and the responsibility or the approach to solving those would differ. So do you have any data from some of the IDEA sites on the CD4 at presentation or at the time of testing that would allow us to figure out where to put the next efforts?
Yeah, so sadly for our databases, we often only have the patients in our databases after they started ART. But there have been 2 meta-analyses which looked at the CD4 cell count at presentation. One by Siedner looking at the CD4 in sub-Saharan Africa at presentation, and one by Lesko, I think, looking in developed countries. And they have actually both have shown that there doesn't seem to be an increase in the CD4 cell count at the presentation.
All right. I don't see any other person coming to the mics. Well, Nanina, thank you very much. Our second presentation is by Jean-Daniel Lelièvre from France, and he's going to present on optimal phase 3 trial, Maraviroc plus ART in advanced HIV-infected individuals. Jean-Daniel.
Thank you. I would like to thank the organizer to give me the opportunity to present you on behalf of our group the result of the optimal trials that aim to explore the effect of adding Maraviroc to combine antiretroviral therapy in advanced late diagnosed HIV-1 infected patients. So for many patients, HIV diagnosis is made late in the course of the disease, and Nanina show you a recent results on these topics. And late HIV diagnosis is associated with an excess risk of AIDS-defining events and mortality. Several trials have failed to demonstrate in the past the clinical benefit of adding a fourth antiretroviral drug to standard 3-drug regimen in those patients. However, we have explored an alternative option and hypothesized that due to its immunomodulating effects, the addition of Maraviroc to standard CRT in naive patients with low CD4 cell counts will decrease the risk of disease progressions and death. Optimal trial was a randomized double-blind trial performed in HIV-1 infected patients with an AIDS-defining events and or CD4 less than 200 cells per ml. They were naive for any kind of antiretroviral therapy. They were stratified according to the country and initial treatment regimen. They received during the whole duration of the study antiretroviral therapy according to recommended regimen plus either Maraviroc or placebo. The study was performed in 50 clinical centers in France, Spain, and Italy. Patients were followed for 72 weeks from September 2011 to March 2016. The primary endpoint of the study was the occurrence of a severe morbidity, which is a composite criteria including different kinds of endpoints, such as new AIDS-defining events, non-B or C events, including opportunistic or severe uncommon infections, severe bacterial infections, or lymphomas. Serious non-AIDS events, including severe cardiovascular, renal, and hepatic diseases, non-AIDS-defining cancer, except for epithelial skin cancers. IRIS defined according to international criteria and all cause of mortality. 459 patients were preselected to be included in the study. 416 were randomized, and at the end, 409, 207 in the placebo arm and 202 in the Maraviroc arm received at least one dose of the experimental treatment and were included in the final intention to treat analysis. Baseline characteristics were well balanced between the two groups. The median age of patients were 32 years. They were predominantly males, half of them being men who have sex with men, and 15 were from sub-Saharan Africa. As expected for this kind of target population, the baseline viral load was quite low, 5.4 log copies per ml. Viral tropisms at baseline was mainly CCR5. CD40 cell count was 80 cells per ml, and the CD4 to CD8 ratio was quite low, 0.11. Despite these findings, only 42% of the participants had an AIDS-defining events at screening. Antiretroviral treatment include PI in 2/3 of patients and other integrase inhibitors or NRTI in the remaining third. During the 72 weeks of follow-up, a total of 74 events were reported in 53 participants, 42 events in 27 participants in the placebo group, and 32 events in 26 participants in the Maraviroc group. As you can see here, we did not see differences between the two groups in the incidence of the primary composite endpoints, with 11.13, the incidence, of 11.13 per 100 person year in the Maraviro group, and 11.22 per 100 person year in the placebo groups, with an hazard ratio close to 1. There was also no difference regarding the occurrence of the different components of the primary endpoints: adverse events, non-BRC events, serious non-AIDS events, or IRIS. We only see 4 deaths in the placebo group and no death in the Maraviro group, which preclude to make any statistical analysis difference between the two groups. A subgroup analysis was also performed trying to analyze different parameters such as country, art, age, gender, origin, CD4 baseline, viral baseline, initial tropisms, AIDS, CD4, CD8 ratio. Once again, we did not see any kind of difference between the two groups. While there was no difference at the end of the study, the Kaplan-Meier analysis clearly show that the kinetics of the occurrence of the endpoints was different between the two arms. We therefore perform a post-hoc analysis using Poisson regression model to explore the treatment effects according to the study period, either between week 0 and week 24 or week 24 to week 72. As shown here, there is a clear difference in the incidence risk ratio between the two periods in favor of Maraviro in the first one and in favor of placebo during the second one. Regarding virological success, we observe a difference at week 82 in favor of the placebo arm, especially in patients with the highest viral load. However, this difference was no more significant at the end of the study. The gain in CD4 were the same at the end of the study between the two groups, and here you can see that there is no difference in terms of kinetics of CD4 T cell restoration between the two groups. Finally, we observed 154 severe adverse events during the study, 18 in the placebo groups, with 8 that have been considered to be related to the treatment, 66 in the Maraviro group, with 27 considered to be related to the treatment. 4 pregnancies occurred, but no neonatal pathologies were reported during the study. And as I previously mentioned, 4 patients of the placebo arm died during the trials, and no death was observed in the Maraviro arm. So we may conclude that adding Maraviro to standard combined antiretroviral therapies during 72 weeks in HIV-infected patients, individuals diagnosed at late stage, had no impact neither on the risk of occurrence of infection or serious events or mortality, nor on virological control or CD4 T cell restoration. However, post-hoc analysis showed that Maraviro might have had a beneficial effect on the occurrence of clinical events during the first 6 months of use, which subsequently disappeared. I would like to thank all the people involved in this trial, members of the INSERM U1136, members of the Fundación Égida in Spain, of the San Raffaele Instituto in Milano, our founders, INSERM ANRS and Pfizer Viv Healthcare, members of the trial coordinating committee chaired by Professor Yves Lévy of the Event Review Committee and of the DSMB. And obviously, I'd like to thank all the patients and staff from all the centers that have participated in this trial. Thank you.
Thank you, Jean-Daniel. Now this presentation is open for Q&A. All right, number 5. Go ahead.
Thank you for the talk. I'm David Asmuth from the University of California in Davis. We ran a similar clinical trial looking at immune reconstitution in the gut in 3 arms. 2 of them compared Maraviro with or without raltegravir with the background of Truvada, and then another
Sorry,
arm.
can you go closer to the microphone, because it's quite difficult to hear you.
I'm sorry. So, and then the third arm was the comparator arm was with the Favrans. And what we found in a favorable effect with the Maravirac-containing arm was in immune reconstitution in the gut with respect to CD4, CD8 counts, as well as immune activation. Were you able to look at either of those parameters in your cohorts?
Sorry, the question was about the CD8 restoration, because I don't hear you clearly.
A CD4, CD8 ratio and
yes.
CD8 activation in the,
Yes.
in the Maravirac-containing arms.
Yes. Unfortunately, I don't have yet the results from the CD8 T cell counts in those patients, because as everybody may be aware of, there is a clear effect of Maravirac on CD8 T cells, but we don't have yet these results.
Thank you. Microphone number 3.
Hello? Okay. Kenny Mercer from New York. 2 questions. One reflects the graph you showed comparing the placebo versus the Maravirac, and it seemed that CD4 count was similar after 6, 8, 12 months. So does that mean that placebo is real placebo and these patients had no treatment whatsoever and they did just as well as patients who received? That's almost counterintuitive. We expect that patients receiving no therapy would, their parameters, their immunologic and virologic status would in fact decline over time.
They receive a real placebo and not during the study.
How do you explain that their results was just as good as people received medication?
Yes.
Yeah. Go ahead.
So sorry, it was not clear for me. What was your question?
How do you explain that patients who received no medication
Yes.
did just as well as people who received medication?
So, sorry, I understand your point. But they receive standard CR regimen either or not with placebo, with Maravirac.
So they received a standard background therapy, and it was placebo versus Maravirac. Is that what it was?
Yes, it was a 3-drug regimen according to a local recommendation plus Maravirac or placebo.
Oh, I see. That's clear. And the second question I had, so that wasn't clear from what you presented. Okay, and the second question is, the second question is, would I've seen in my treatment clinically that patients have done well with or without Maravirac. With this study, in a forward step, could you suggest then perhaps that patients who are taking Maravirac could perhaps eliminate that from their therapy and do just as well with a reduced regimen and reduced pill burden?
I think that at the end of the study we can conclude that there may have a benefit to add Maravirac during the first 6 months in terms of clinical events, but we don't see any effects on viral control or HIV reservoir, for instance. So the only add value of Maravirac is to prevent the occurrence of some clinical events during the first 6 months.
Thank you. We shall go to number 4. That will be the last question, yeah.
Stefan de Witt, Brussels. You showed inferiority of the Maravirac combination at week 48, virological inferiority. Was it the same in all groups, whether they were on PI or non-PI regimens, because of the issue of potential interaction PI-Maravirac?
Yes, no, there was no difference regarding the baseline treatment regimen.
Thank you very much, Dr. Lelièvre. We shall move on to the third presentation by Dr. Raoul Mon from Félix Houphouët-Boigny University in Abidjan. 48 weeks efficacy of a third-line-based darunavir plus raltegravir regimen in HIV-infected adults who failed second-line protease inhibitor-based regimen in sub-Saharan Africa. Theliao study.
Thank you, Mr. Chairman. And thanks to the IAS organizers for giving us the opportunity to present the final results of the Theliao study, reinforcement of adherence and switch to third line in HIV-infected adults who failed second-line ART in West Africa. In sub-Saharan Africa, ART regimen sequencing is based on the WHO guidelines that recommend to start with an NNRTI-based regimen and then switch to a PI-based regimen in case of virological failure. In the recent years, there has been an increase in the access to viral load monitoring and to second-line drugs. Because of this, there has also been an increase in the number of patients on second-line ART diagnosed with virological failure. Meanwhile, access to resistance tests and to third-line drugs remain low. In this context, there is a need for strategies that help physicians to decide when to switch to third-line ART. Not too early, in other words, switch to third line when you have virological failure but still a high genotypic sensitivity score. And not too late, in other words, delay the decision of switch that leads to the risk of accumulating resistance. We did a pilot study named Theliao to assess one of the strategies in 4 West Africa countries, Burkina Faso, Côte d'Ivoire, Mali, and Senegal. We included in this study adults who were on a PI-based second-line ART and had confirmed virological failure, defined as 2 viral loads above 1,000 copies within the past month. The Theliao study had 2 phases. During the first month, participants had an intensive adherence reinforcement program that I will detail in the next slides. During this phase, they continued the previous treatment. At month 4, a decision was taken based on the effect of adherence reinforcement on the evolution of viral load. If viral load fell below 400 copies or decreased more than 2 logs compared to baseline value, patients continued the second-line treatment. Otherwise, they switched to third line. The study primary outcome was virological success at month 16, defined as viral load below 50 copies. The secondary outcomes were death, resistance, and tolerance. All participants had therapeutic education and then chose as many adherence reinforcement measures as they wished among the following: involvement of a relative, pill organizer, weekly phone calls, alarm reminders, SMS, home visits, extra visit to the study center, support group, adjustment of ART drug doses, adjustment of non-ART drugs. Viral load was measured every 3 months, with results provided in real time to clinicians. The month 3 results was used to inform the month 4 decision. If the decision was to continue second line at month 4, a switch to third line was further proposed whenever the patient had 2 consecutive viral load above 1,000 copies at any time during follow-up. Resistance tests were performed at baseline and at month 16 for all samples with a viral load about 400 copies. The results of this test were only available at the end of the study. They were used retrospectively to interpret the decisions taken at month 4 which could only be based on the effect of adherence reinforcement on the evolution of viral load. The decision taken at month 4 was retrospectively deemed inappropriate if the decision was to switch, but the resistance test retrospectively showed that there was no resistance to the ongoing PI, and the genotypic sensitivity score, was 3 or above. Or if the decision was to continue second line, but the resistance test retrospectively showed that there was a resistance to the PI, or the genotypic sensitivity score was below 2. In all other cases, the decision was deemed appropriate. Finally, resistance accumulation was defined as new resistance mutations occurring between day 0 and month 16 in patients with a viral load above 400 copies at day 0 and month 16. 198 patients were included in the study. The median age was 41 years. The median baseline CD4 count was 238. The most frequent ART regimen was TTF-XTC plus lopinavir ritonavir. The median time spent on ART was 8 years overall, 3 years on first line, and 3 years on second line. The median viral load was 4.5 log. After the phase of adherence reinforcement, during which 2.5% of patients died, the decision at month 4 was to continue second line in 66% of patients and to switch to third line in 32%. Overall, at the end of the study, 8% of patients had died, 2% were lost to follow-up, 51% were alive and in active follow-up with a viral load below 50 copies, 23% at between 50 and 400 copies, and 17% at more than 400 copies. Patients who continued second line or switched to third line at month 4 had similar percentages of virological efficacy at month 16. Between 70 and 80% of patients had less than 400 copies, including between 50 and 60% with less than 50 copies. When considering the probability of having at least one viral load below 50 copies during follow-up, patients who continued second line or switched to third line at month 4 also had similar probabilities of reaching less than 50 copies at least once. These probabilities are higher than the percentage of patients with less than 50 copies at month 16 that we saw in the previous slide, because some patients who reached less than 50 copies at least once at more than 50 copies at month 16. And finally, here is the detail of the other outcomes. According to month 4 decision, as you can see, third-line drugs were very well tolerated. Among patients with more than 400 copies at month 16, 82% and 71% had one resistance mutation to at least one ART, respectively. Resistance mutation accumulation was found in 5% and 3% of patients, respectively. And when the results of the resistance tests were available, month 4 decision was deemed appropriate in 81% and 73% of patients, respectively. In conclusion, in settings where viral load tests are routinely available, but not genotypic testing, an intense adherence reinforcement phase used as a tool to distinguish between patients who can still benefit the current regimen and those who truly need a potent third-line ART allowed us to take appropriate decision of switching or not switching in most patients. Resistance accumulation was rare, and third-line drugs were well tolerated. Accessibility to viral load monitoring, to third-line drugs, and to adherence reinforcement measures should be reinforced. Our thanks and gratitude go first to the participants in the study, and then to all those persons and institutions who took part in the realization of this study. I thank you for your attention.
Raul,
Yes.
adherence was obviously a very important aspect of your study. Was there any way that you were able to measure or get an assessment of adherence at the start of study and also subsequently to determine, even though I know each participant chose what adherence strategy would be applied to them. I know it's pretty heterogeneous, but was there some measure of adherence before and during the study?
People are invited to choose one of the 10 measures during the 3 months. And after the 3 first months of adherence reinforcement, there were follow-up between 4 months and 16 months. And during all this follow-up, they had adherence reinforcement during all the follow-up, just until the end of the follow-up. Okay, before the inclusion of in the study, you have 33% who had a previous adherence reinforcement in the care center of HIV. Okay. Yes, we asked to the patients, have you already had adherence reinforcement before your inclusion in the study? And the answer was yes for 33% of the participants.
Okay, thank you. Microphone number 5.
I'm Prapan Panupak from Thailand. With the beautiful results that you have shown, do you think that you would recommend WHO to change the recommended guidelines for first line, second line, and third line therapies?
No, I don't. No, I don't think so. The AIT sequencing recommended by WHO is fair, and we don't ask to WHO to change the recommendation, but we show here the adherence reinforcement and the efficacy and effectiveness of adherence reinforcement pending genotyping testing.
Thank you. Number 6.
Nick Payton, National University of Singapore. There's currently a debate on the value of resistance testing in the public health approach, with a number of groups advocating the introduction of such testing to help guide regimen choice, and other people saying actually it probably doesn't contribute much. Certainly for the choice of second-line regimens, where you've got non-overlapping, a new class being introduced, it appears to have not much value. Some people argue that, well, third-line therapy, it might have more value. So can I ask you just to comment on, based on your results, the value of resistance testing for third-line therapy? Do you feel that actually this would contribute something, or would be a complete waste of resources?
We, in our study, use the viral loads to take a decision after the adherence reinforcement. We noticed in our conclusion that genotypic testing is not routinely used in our practice, in our limited settings, limited resources settings. So we we make advocacy for that to reinforce and to improve the accessibility of genotypic testing. But we show how we do and what we do in our settings without genotypic testing not routinely available.
Okay, thank you. We'll take the last question from microphone number 4.
Okay, thank you. Tyson Lee from Beijing, China. So thank you for your presentation. I think the results about you treat your patient with third line and after treatment, the virus suppression rate is 59% is lower. I think principally that's because the adherence is not so good as the chairman mentioned. Because as in China, we even switched to second line. After 1 year treatment, we have more than 70% patients have a viral suppress completely. So the adherence is the most important factor. Thank you.
We agree with you. 59% of participants below 50 copies at the end of the follow-up, it's now so wonderful and fantastic. But don't forget that there are participants who had a long history of adherence concerns. So at the end of the follow-up, we have more than 70%, below 400 copies per millimeter. So we agree with you, 59% is not so fantastic. But when we take a look on the history of serious adherence concern that the participants have, we are a little bit satisfied.
Thank you very much, Dr. Moore.
Good morning. It's my pleasure to introduce the next speaker, Dr. Joe Garland. He is the Medical Director of Specialty Services, Southwest Care Center, USA. He's gonna present a phase 3 randomized controlled trial of bictegravir in a fixed-dose combination, BF-TAF, versus abacavir, dolutegravir, 3TC in treatment-naive adult at week 48. Dr. Joe, please.
Good morning. Bonjour. I want to, on behalf of my co-investigators, thank the organizers for inviting us to present the data of GS 1489 here. As background, integrase strand transfer inhibitors are recommended by multiple international guidelines as components of first-line therapy in combination with 2 nucleoside analogs. Bictegravir is a novel potent integrase inhibitor with a high in vitro barrier to resistance and low potential for drug interactions. Bictegravir plus emtricitabine and tenofovir alafenamide, or FTAF, was studied in a phase 2 trial compared to dolutegravir in FTAF and was found to be safe and effective with no development of resistance to any of the study medications. Bictegravir has been co-formulated into a single tablet regimen with emtricitabine and TAF. I will be referring to that as BF-TAF from here on. And it is used for, it's formulated for once daily dosing without regard to food. This is the study design for GS 1489, which is a phase 3 randomized, double-blind, active controlled study conducted in North America and Europe with stratification by viral load, CD4 count, and geographic region. Because participants could have been randomized to receive the abacavir lamivudine nucleoside backbone, they had to have estimated GFRs of at least 50, they had to be HLA B5701 negative, and they had to be negative for chronic hepatitis B. 629 patients were randomized to receive either BF-TAF with a dolutegravir abacavir lamivudine placebo, or dolutegravir abacavir lamivudine, which I'll be referring to as the dolutegravir arm, plus a BF-TAF placebo. And we'll be looking at the primary endpoint, 48 weeks. Here's the participant disposition. 739 were screened, 631 randomized, of whom 2 were not treated. So we have 629 who were randomized and treated. And you can see the reasons for discontinuation occurring in about 5 to 6% of participants. No significant differences between the 2 arms with the exception of adverse events, which we'll come back to later. Here are the baseline characteristics, and they're fairly typical for a treatment-naive study these days. Mostly male. There was a fairly good racial and ethnic diversity. Viral loads were not terribly high. 16 to 17% had viral loads above 100,000, and about 10 to 11% had CD4 counts below 200. And of course, as is typical of a treatment-naive trial, patients had kidney function that was well within the normal range. All right, so here are the results, the virologic outcome at week 48 primary endpoint. You can see very high rates of success in both arms, 92.4% with BF-TAF and 93% in the dolutegravir arm, having suppressed to less than 50 copies. Very low rates of virologic non-response, 1.0 and 2.5%, and no real difference in the no virologic data category. So with the lower limit of the confidence interval of 4.8 being well above the 12, non-inferiority of BF-TAF was clearly established. In addition, we did some pre-specified sensitivity analyses, which again confirmed non-inferiority with the per-protocol analysis, missing equals failure analysis, and missing equals excluded analysis. Finally, and not surprisingly, CD4 counts did not differ. There was about a 230 cell increase at 48 weeks in the two arms. A few patients met criteria for resistance testing, which was to have a viral load above 200 that was confirmed after 8 weeks, or above 200 at the last visit. A total of 5 subjects met the criteria, 1 in the BF-TAF arm, 4 in the dolutegravir arm. There was 1 assay failure, but overall no resistance to any components of the treatment regimens occurred in either treatment group. Here are the adverse events leading to study drug discontinuation. There were none in the BF-TAF arm. There were 4 in the dolutegravir arm that were attributed to drug by the investigator. One was a early nausea and rash with some fever, and there had been concern about a hypersensitivity reaction to one of the components. There was a thrombocytopenia at day 50. This was a patient who had ITP at baseline that got worse on treatment, a chronic pancreatitis, and depression at day 248. There were no deaths reported in either treatment arm. Here are the all-grade adverse events that occurred in at least 5% of the population in either arm, and there's really nothing here except for nausea, where you see that 10% of BF-TAF recipients reported nausea compared to about 23% of dolutegravir recipients. In a post-hoc analysis, that difference was statistically significant with a p-value of less than 0.001. Now, here's an early look at patient-reported outcomes. There will be more coming later. This, in particular, is looking at the HIV symptom distress module, and what we've done is shown in green time points and symptoms where there was a significant difference favoring BF-TAF. Had there been any differences favoring dolutegravir, they would have been in black, but there were none. You can see it's mostly gastrointestinal side effects and neuropsychiatric or CNS, I shouldn't say side effects, symptoms. Note that difficulty sleeping, there was no significant difference in this particular module. However, in the more specific and detailed Pittsburgh Sleep Quality Index, higher use of sleeping medication at week 4 was reported with dolutegravir, and more sleep disturbance at week 48 was also reported in the dolutegravir arm. These are laboratory abnormalities occurring in at least 2% of the study populations through week 48. Not much here, with the exception of that one case of pancreatitis in the dolutegravir arm. The amylase elevations were asymptomatic. Now, of course, we've been used to seeing in a number of clinical trials an early decline in estimated GFR due to a number of antiretroviral agents that increase serum creatinine without causing true nephrotoxicity. We've known, of course, that dolutegravir does this. Bictegravir does it as well. So you see this modest early decline at 4 weeks in estimated GFR that then stabilizes over time. And in this particular trial, there was no difference between the two arms and no discontinuations due to renal adverse events or proximal tubulopathy in either arm. We've also been used to looking at TAF and TDF comparisons in terms of both overall and tubular proteinuria, which tend to favor TAF. Of course, this is now a comparison of TAF with abacavir, a drug that has not been associated with kidney toxicity, and you see no differences in urine albumin creatinine ratio or in the tubular markers, retinol binding protein creatinine ratio or beta-2 microglobulin creatinine ratio. Note that the latter, the beta-2 microglobulin, is an acute phase reactant, so as patients get put on antiretroviral therapy and their viral load is brought down, that does tend to decline. And then in bone, again, we've been used to seeing TAF versus TDF comparisons, where TAF has less of an effect on bone mineral density than TDF. Abacavir has been a drug that has been recommended for patients with bone issues, and here we see no differences in bone mineral density changes in both the spine and the hip between the BF-TAF and the dolutegravir regimen, with very modest declines through 48 weeks. And finally, lipids. You do see a modest rise in all of the lipid components, including HDL cholesterol, but no significant differences between the arms, and no significant difference in terms of patients who were on lipid-lowering agents at baseline or who started lipid-lowering agents over the course of the study. So to conclude, initial therapy with BF-TAF was non-inferior to dolutegravir, abacavir, lamivudine at week 48 by the snapshot algorithm, as well as by some other sensitivity analyses that were performed. 92.4% were suppressed on BF-TAF, 93% on the dolutegravir regimen, and there was no emergence of drug resistance to any component of either regimen. BF-TAF was well tolerated with no adverse events leading to discontinuation, though nausea was reported significantly more often in patients treated with dolutegravir. In terms of patient-reported outcomes, we saw gastrointestinal, neuropsychiatric, and sleep-related symptoms that were reported more often in patients treated with dolutegravir compared to BF-TAF. And there were changes from baseline in bone mineral density, lipid parameters, and renal markers that were comparable between arms. So in terms of future directions, the manuscript for these data has already been submitted to a peer-reviewed journal. The results from another naive study, phase 3, of BF-TAF versus dolutegravir F-TAF will be presented tomorrow at 1 o'clock by Paul Sachs at a poster discussion, and I'd encourage you to take a look at that, where the only comparison in that study is between dolutegravir and bictegravir. 2 switch studies in virologically suppressed patients have reached their primary endpoints and will be presented at upcoming conferences. And a fully enrolled study of 440 women will reach its primary endpoint in early 2018. There's an ongoing study of BF-TAF in adolescents and children. And finally, regulatory filings of BF-TAF have been submitted to the FDA in the United States, to the EMA, and to other regulatory authorities. I would just also make a personal comment that this is an attractive regimen for what people are often referring to as rapid start, where we start therapy without having laboratory results. The advantage of BF-TAF here is that you can start without knowing hepatitis B status, without doing HLA 5701 testing, and without having renal function information because of the low threshold for GFR to start this agent. I would like to thank the investigators, the study staff, and of course, especially the participants in the study. Thank you for your attention.
Thank you very much. Microphone number 5.
So, Monica Gandhi from UCSF, thank you, Joel, for that wonderful presentation. My question was at the beginning when you presented the demographics of the patients enrolled. that you made a comment that this is typical at this point to have something like 90% men enrolled in trials. It isn't typical. Things were actually getting better in terms of the percentage of women enrolled in trials until pretty recently, over the last, I think, 5 years with the integrase inhibitor trials, that we were getting more and more percentage of men enrolled for expediency. I don't think 90% men enrolled will ever allow women-controlled comparisons, especially with the later data coming out with integrase inhibitors of seeing more side effects in women. So I'd encourage drug companies to go back to the old principles of, in phase 3 trials, still thinking about trying to enroll women that are more concomitant with the percentage reflected in the epidemic. I recognize there's going to be I do recognize there's going to be a phase 4 trial, as you mentioned at the end, as there often is with women enrolled in an exclusive women-controlled study at the end, but that doesn't give us the knowledge when a drug is first approved. My second question was, is there any data on drug-drug interaction data between bictegravir and dolutegravir with other drugs that are in the regimen? There was some data at CROI about drug-drug interactions between the two, and wondering if that's going to have anything that we can think of as clinicians, because I think this will probably push forth the approval of this agent.
I'm sorry, can you clarify which interactions you're referring to, Monica?
So what was talked about at CROI was the rifampin interaction with bictegravir and dolutegravir, that we're not going to see an advantage here with bictegravir in terms of being able to co-administer with rifampin, for example. Any other drugs that are coming up that you think will have an advantage with bictegravir, with drug-drug interactions that we couldn't get with dolutegravir? I know that bictegravir is metabolized through two different pathways, and that can be good and bad with interactions. It can either mean fewer or more.
Well, you know, first of all, remember, of course, it's not just with rifampin, it's not just the bictegravir, but the TAF that it's co-formulated with, which also creates a problem with rifampin. So that's really not a possibility. You know, dolutegravir has fairly few interactions. Bictegravir has few interactions. I'm not sure I can point to any specific difference right now that's going to favor bictegravir in terms of the few drug interactions that both drugs have.
So, microphone
and
number
I
two.
thank you for your point about the women. It's an excellent point.
Okay, number 3.
Thank you. Laura Waters from London, UK. 2 quick questions. One, you showed the lipids. Certainly the difference in LDL was approaching significance. I didn't see any ratio data. Could you comment on that? And secondly, you talked about the regulatory plans for BF-TAF. What are the regulatory plans for B alone?
B. Okay. So for the ratio, total cholesterol to HDL ratio, there was about a 0.2 decline with dolutegravir arm, 0.3 with BF-TAF. The difference was significant, but the numbers were small. The difference was small. There is no plan at the present time for approval of bictegravir as a standalone product.
Number 4.
Keith Crawford, National Institutes of Health, Washington, D.C. So I'm concerned about how these two regimens compared in the patients with over 100,000 viral load. There's been some concern with the abacavir-containing regimens, but that has usually been in studies with NNRTIs or protease inhibitors. So I don't know if you looked at that particular group of patients.
Well, you saw that we did have people with viral loads above 100,000, but it was not a large number. As you point out, the concern about abacavir with high viral loads has been limited to other regimens that don't include dolutegravir, and at the present time there's no limitation on viral load for that particular regimen, dolutegravir, abacavir, lamivudine. We would assume that would be similar for BF-TAF, since tenofovir has never had that limitation. But we have the numbers that we have in terms of baseline viral load.
So because the time, so I go with the last question, the number 6.
Bronx, New York, VA Hospital. There was one table where you showed multiple improved outcomes in the patient-reported outcomes of the BF-TAF versus the other group. I assume this was a pre-specified protocol-driven analysis. And if so, which p-value did you use? Was that 0.05 or was that p-value adjusted for multiple testing according to the Bonferroni method?
That's a good question, one that I cannot answer here. So we will get the answer to you, but keep in mind that this is a very early look at the PROs, and we will be already are looking more closely at PROs, and we'll be presenting more data that will include severity and things like that. But I can't answer your statistical question. Thank you.
Thank you. The next speaker is Dr. Peter Carnes. He's from the University of Buenos Aires Medical School from Argentina. The abstract is dual therapy with darunavir ritonavir plus lamivudine for HB1 treatment initiation with 24 results from the randomized NDES study. Dr. Peter Carnes, please.
Thank you very much. I would like to thank the organizers for inviting our paper to be presented as a late breaker at this important conference. I am presenting the results of the first results of the ANDES study on behalf of the ANDES study group. This is a phase 4 randomized open-label study of a ritonavir-boosted darunavir in fixed-dose combination, which I will explain a little bit more, plus lamivudine, compared to the same fixed-dose combination of darunavir-ritonavir plus tenofovir-lamivudine in HIV-infected naive subjects. This is an investigator-initiated study designed, conducted, and sponsored by Fundación Huésped, my organization. Funding sources were the Ministry of Science and Technology and the Ministry of Health and the Richmond Laboratories, all from Buenos Aires, Argentina. What's the background for this study? You might remember that the Gardel study, which we also ran, demonstrated non-inferiority of a two-drug regimen combining a boosted PI and lamivudine when compared to standard of care HART in treatment-naive patients. In virologically suppressed patients, similar strategies showed non-inferiority when compared to triple therapy, namely the OLE study, the ATLAS-M, which eventually showed even superiority for the dual therapy strategy, and the dual study that was performed by the Spanish group with darunavir, ritonavir, and 3TC. ANDES study was designed to explore the efficacy and safety of ritonavir-boosted darunavir plus 3TC compared to the same PI plus tenofovir 3TC in treatment-naive patients. Why did we select these drugs? Well, you know, darunavir-ritonavir is a potent antiviral compound with proven clinical efficacy in both treatment-naive and treatment-experienced HIV-infected patients with high genetic barrier, and is the preferred PI in those guidelines that still keep PIs as first line. 3TC, in turn, is a safe and well-tolerated drug. It's cheap and generic. Both drugs allow for a once-daily dosing. Both are well-tolerated with minimum monitoring requirement. We have in Argentina a fixed-dose combination of darunavir 800 mg plus ritonavir 100, which is registered and approved to be used in treatment-naive patients since 2015. As you can see here, this is a snapshot of the PK data, both for Cmax and for area under the curve. The curves are very similar. The reference is branded darunavir from Janssen's, and the blue curve is the drug we are using here, and you can see in the bottom of the slides how the pills look. So the study was designed in two phases. We tried to be very carefully when we explore dual therapy because you never know what's going to happen. So we decided to have a first phase with a minimum of 140 participants that were required to study non-inferiority at 24 weeks at the threshold of 400 copies per ml. If at 24 weeks at least 75% of the participants would achieve viral suppression at that level in the experimental arm, then the study would proceed to phase 2, which would require 190 additional patients to be enrolled to explore non-inferiority at 50 copies at week 48. So the study design is pretty straightforward. As you can see, patients had to be naive. They came from 5 different sites in Argentina with at least 1,000 copies. No IAS USA panel defined resistant at screening, they had to be Hep B negative because we don't want to expose patients to 3TC monotherapy. And patients were randomized 1-to-1 either to the dual therapy arm or to the triple therapy arm. And I'm presenting now the results of the week 24 interim analysis. Just to be reminded, the primary endpoint of the study will be reached at week 48, provided that we are able to fund the study in order to complete it, with the being less than 50 copies at week 48 using the FDA snapshot algorithm. And in bold letters, you can see the secondary endpoint that I'm presenting today, that is at week 24, proportion of patients with less than 400 copies per ml using the FDA snapshot algorithm in the intention to treat exposed method. So we screened 182 patients and 145 out of them were randomized. We had a 20% rate of screening failure, mainly because of some resistance or viral load below 1,000 copies, lost to follow-up, etc. So at the end of the day, we finished with 75 patients in the dual therapy arm and 70 patients in the triple therapy arm. We had 5 discontinuations, 4 in the dual therapy arm, 1 patient withdrew consent, 1 had a severe adverse event not related to the study, 1 lost to follow-up and 1 rush, and 1 discontinuation in the triple therapy arm that was a loss to follow-up. So at the end of the day, the completion at week 24 was 95% for the dual therapy arm and 98.5% for the week 24 for the triple therapy arm. Sorry. Baseline characteristics, as you can see, they were well balanced. Again, apologies for that. Predominance of males. Most of them were MSM or bisexual. We had no CDC stage 3, stage C cases, but we had 8% and 7% respectively with stage B. Median viral load was 4.5, and we stratified our patients. The randomization was stratified by viral load below or above 100,000 copies, and as you can see, 27% in the dual therapy arm and 22% in the triple therapy arm had that viral load at screening. Median CD4 count was around 400 CD4s in both arms. So this is the graph of the results. As you can see, 97% of the patients in triple therapy and 95% of the patients in dual therapy with a point difference of 2.5 show these results are showing non-inferiority. The CD4 gain was about 200 cells in both arms. If we analyze on the on-treatment patients, excluding those that discontinued and patients that had the virological failure, you can see that the results were 100% in the dual therapy arm and 99% in the triple therapy arm, with only 1 patient failing because of lack of adherence. Regarding patients with more than 100,000 copies, 20 patients in the dual therapy arm and 15 patients in the triple therapy arm achieved 100%, as you can see, the secondary endpoint that we are talking about in this presentation. Regarding adverse events, we had 11 adverse events in 10 patients in the dual therapy arm and 21 adverse events in 16 patients in the triple therapy arm. And what was a little bit surprising for us was that we saw numerically more in the triple therapy arm in terms of gastrointestinal side effects that we have to attribute to the issue of using tenofovir in one arm and not using it in the other one. Rashes were mainly attributed to darunavir. And regarding neurologic events, we saw 3 in the triple therapy arm and none in the dual therapy arm. Addressing serious adverse events, we counted 8. None of them was considered drug-related. 3 happened during the screening period, so I will not comment about that. And we had 5 during the study period. As you can see, 3 in the dual therapy arm, community-acquired pneumonia, asthma, and diverticulitis, and 2 in the triple therapy arm, community-acquired pneumonia and diabetic foot, so none of them was considered by the investigators to be related with the study drugs. So in conclusion, a generic combination of darunavir, ritonavir in fixed-dose combination plus 3TC showed non-inferiority on a secondary endpoint to a generic triple drug regimen of darunavir, ritonavir plus tenofovir 3TC at 24 weeks in treatment-naive patients. These results, if confirmed at week 48, may provide further evidence about the potential efficacy of dual therapy based on 3TC and a drug with a high genetic barrier. I would like to acknowledge, first of all, the patients and their families, the understudy team, our investigators at Fundación Westprint, namely Mariana Figueroa, who was the leader of this project, our colleagues at Hospital Argerich, Italiano, Centro de Estudios Infectológicos and Consultorio Infectológico, and the coordination team at the UM Gardel, Richmond Laboratories by Elvira Cini, and again, the funding from the Ministry of Science and Technology, Ministry of Health, and Richmond Laboratories. I thank you very much for your attention.
Thank you very much. So, did you do the genotypic resistance testing at baseline?
Sorry?
The genotypic resistance testing, did you do it at baseline?
I cannot hear your question.
Genotypic
Do you do genotypic resistance testing?
baseline, yeah.
Sorry about that. Yes, we perform resistance testing, and any patient with resistance to nucleoside or to PIs would be excluded from the study. Will not be included, by the way.
Any other questions? Okay, no, thank you very much.
Thank you.
So let's move to the last speaker, Dr. Babafemi Taiwo from Northwestern University, USA. The abstract is ACTG A5353, a pilot study of dolutegravir plus 3TC for initial treatment of HIV-1 infected participants with HIV-1A. Okay, Dr. Taiwo, please.
I'd like to thank the organizers for the opportunity to present our data from the ACTG A5353 study. Here are my disclosures. As background, dolutegravir plus lamivudine is an investigational two-drug regimen with several strengths. The potency of the drugs, the well-tolerated. Dolutegravir has robust resistance profiles demonstrated in multiple clinical trials. Now, with the addition of bictegravir study, up to or close to 2,000 participants with no resistance. There's potential for co-formulation and possibly reduced risk of adverse events. And in one estimate, it could save in excess of $500 million and up to $3 billion in the US alone over 5 years. There's, however, several unknowns and potential weaknesses, including efficacy at high baseline viral load is unknown, the low resistance barrier of 3TC, contraindication with hepatitis B, and unknown efficacy in the compartments, as well as pregnancy. We have some preliminary data about this two-drug regimen provided by Pedro Can in the PADL study, in which he demonstrated in 20 subjects viral load suppression in 18 at week 48. That study, however, had some limitations, including the small sample size. It excluded participants with viral load over 100,000, CD4 count less than 200, and overall, it was not sufficient to justify enrollment of participants with high viral load studies in large trials. In addition, genotypic testing was limited as there was only one failure who really had no RT resistance, while integrase did not amplify. We therefore conducted the A5353 study as a single-arm phase 2 trial, 52 weeks, using 50 milligrams of dolutegravir, 300 milligrams of 3TC. In this study, we aimed to enroll participants with higher viral load than the PADL study, and we set a viral load cap at less than 500,000. Our primary objective was to estimate the virologic success rate at week 24. We also had some secondary objectives, which are shown here. We wanted to compare efficacy between the high and low viral load groups, wanted to look at resistance emergence during failure, safety and tolerability, and also evaluate minority drug resistance as well as adherence and drug exposure as to their effect on the outcomes. Here are the eligibility criteria. Participants had to have viral loads at least 1,000, but less than 500,000. We pre-specified that 25% of the participants would have a viral load above 100,000. We also required no evidence of RT, integrase, or major PI resistance. And because integrase testing was not standard of care, we performed it as part of the study procedure at screening. Participants had to have hepatitis B surface antigen negative, and although we allowed hepatitis C infection, those who required treatment during the study period were excluded. Here are the outcome measures. We had two main ones. The primary efficacy outcome measure was virologic success at week 24 using the FDA snapshot algorithm and a level of less than 50 copies. We also had another outcome measure, which was virologic failure, which we defined as viral load of greater than 400 copies per mil at week 16 or 20, or greater than 200 copies per mil at or after week 24. Participant disposition up to week 24 is shown here. We screened 165 participants, of whom 43 did not enroll for the reasons shown here. 122 enrolled, and of those, 2 were deemed ineligible because they had exclusionary mutation at the time of enrollment. Therefore, 120 participants entered the study and are included in this analysis. Of those 120, 37 had viral load over 100,000, and 83 had viral load of at least 100,000. In the course of the study, 4 discontinued the study, and 3 discontinued the study but remained discontinued dolutegravir plus 3TC but remained on study. The reasons for those are shown here. In terms of the baseline characteristics, the median age was 30 in both groups. There was a predominance of men. The racial distribution is shown here. CD4 count, we had about 30% with less than 200 in the high viral load group versus 6% in the low viral load group. And also HIV RNA at baseline, if you look at the population with viral load over 100,000 in blue, you'll see that about 38% of them, so about 13 participants, had viral load over 200,000. And here are the results. The primary outcome data using the FDA snapshot at week 24 showed a total suppression rate less than 50 copies per mil of 90%, with no significant difference between both arms. There was also another category of virologic non-success, and in this category were participants who either had HIV RNA at the week 24 time point, and there were 3 participants in that group. In addition, there were 2 participants in the less than 100,000 group who met that criteria for virologic non-success. Now, there were a total of 5 participants in the virologic non-success group. Of those 5, 3 were virologic failures as well. And those 3, 2 were in the less than 100,000 copy group, and only 1 virologic failure in the greater than 100,000 copy group. There was another category of no virologic data in the window, and for you to be in this category, you had to have viral load less than 50 at the last available measurement. And so those 7 participants all had viral load less than 50 at the time they left the study, and none of those was due to discontinuation due to adverse events. So I'm now going to focus on the 5 participants in the virologic non-success group, which, as I said before, had 3 participants with failure and 2 participants who did not fail but met the FDA snapshot definition. So 2 of those 5 participants had viral load greater than 100,000 at baseline. You can see that they both dropped below 50, but at week 24, they had viral loads about 80-something, so less than 200, but they did meet the FDA snapshot definition. The 3 participants who had virologic failure are shown here. Only one of them is in the greater than 100,000 copy group. That participant shown in the top had a high viral load, dropped very quickly to less than 50 copies by week 12, which is shown in blue. In red, however, is the participant's dolutegravir level. You'll see that dolutegravir level was high initially, but coincident with the rebound in virus, which occurred at about week 24, you'll see that that participant had very low dolutegravir levels and unmeasurable dolutegravir levels subsequently while on study treatment, This was a non-adherent patient. The next participant, with less than 100,000 copies at baseline, again dropped the viral load to below detection by week 4 in this case. But the patient had very erratic adherence throughout the study, as shown in red, with multiple dolutegravir levels, or at least one dolutegravir level, being unmeasurable while the participant was on study treatment. We conducted resistance testing in this participant as well as the others, and you'll see that this participant at week 24, when he had virologic failure, had the M184V mutation detected. We also looked more proximally at week 16 and week 8, and at those time points, the patient was still on the study treatment. We detected at week 16 the M184V mutation and the R263RK mixture at week 16, and none of these were found at week 8 or at baseline. This participant also was extremely non-adherent, as shown by the dolutegravir levels. The third participant, again, was very non-adherent, shown in red, with the dolutegravir level at multiple time points while on study treatment being unmeasurable and coincident with virus rebound. This participant had the V106I polymorphism detected during study. It was not present at baseline. CD4 count changes were quite robust in both arms, with 212 median in the greater than 100,000 copy group and 133 in the less than 100,000 copy group. Adverse events were uncommon. Only 2 participants described grade 3 adverse events that were possibly study-related. There were no grade 4 adverse events. There were no discontinuations due to adverse events. In conclusion, in this pilot study, dolutegravir plus 3TC demonstrated potent virologic efficacy with study entry viral load up to 500,000 copies per mil. Virologic failure was uncommon. It occurred in only 3 participants, one of whom had emergent R263RK mixture and M184V. These events were associated with suboptimal adherence. Future work in A5353 includes investigating the impact of minority variants on our findings, and also phenotypic testing to better characterize this clinical significance, if any, of the R263RK mixture. We also plan to embark on some pharmacogenetic studies to better understand our findings. As you know, there are 2 ongoing large randomized studies that will further elucidate these results. I would like to thank the entire A53 study team, especially my co-chair, who's somewhere in the right-hand corner up there, Trip Gillick, and also thank the study sites that participated in the ACTG, sponsors, the NIAID, Viv Healthcare, and most importantly, a big thanks to the participants.
Okay. Thank you very much. So any questions? So, microphone number 3.
Hello. Hi, Chloe Orkin from the Royal London Hospital in London. Fantastically interesting data. I'm on your left. There we go. I guess what strikes me is the fact that 3 patients who had relatively short periods of non-adherence, because if you look at the drug levels, you see that they were pretty high drug levels and they suddenly dropped. And then you notice, you can recognize the drop in adherence and you see a subsequent virological failure. So I guess the question is, in terms of the robustness of the dual therapy regime, how are we going to, in future, qualify the level of adherence required in order to maintain an adequate genetic barrier with this regime, in terms of monitoring of drug levels to ascertain what level of adherence is required to make this regime robust?
Yeah, that's a good question, and I hope that we can get more data from the Gemini studies. I will say, though, that this particular participant who had emergent mutations had particularly chaotic adherence. And when we contacted the site, they almost apologized for putting him in a study. But in fact, we do need participants like this in studies so we can understand what's going on. But to answer your question, I think we have to wait to characterize. But overall, still a robust regimen, I think.
Number 9.
Thanks so much.
And microphone number 9.
Hi, Bart Reinders from Rotterdam. Did you look at mutations that can occur in the integrase binding site? Because we know that not only the integrase gene, but also the binding site can confer resistance, as was shown at CROI by a French group. And unfortunately, we also detected it in one patient in our dolutegravir monotherapy study. It's unpublished yet, but...
We have not looked at that. But again, it will be possible to do that in this 3 participants. We haven't done it, but thanks for bringing it up.
Well, all right. Thank you very much. Well, we've come to the end of the session, and I would like to thank the audience, and I would like to thank the speakers for an excellent session. Thank you very much.